Bueno, tenemos el agrado de presentar al profesor Albert Farrugia, que es un destacado doctor en medicina, es licenciado en química y en biología, tiene más de 150 trabajos publicados de impacto, y bueno, nos va a hablar hoy de un tema muy importante, debatido, la albúmina del enfermo crítico, de la evidencia a la práctica clínica. Adelante.
Buenos dias. I would first of all like to apologize for my inability to address you in Spanish. I am very sorry for this, but I'm sure we have a very good translator. I want to also thank from the bottom of my heart my good new friend, Professor Biestro, for giving me the opportunity to be with you here today and to give me a reason for being again in Uruguay, a country which has my heart in a very strong grip. So, what do I have to do? How do I advance these slides? How do I make it go forward? Okay. These are my disclosures. I have to declare a conflict of interest in some of the things I am going to be talking to you today. And on this question of albumin, I have decided to divide this talk along this outline. I will speak about some current concepts of fluid exchange. I will talk about the basic physiology and pharmacology of albumin. I will then move into what are the best evidence-based indications for using this product. And I think it is important to also talk about the possible estimation of how much albumin is needed and the very important question of cost effectiveness. Albumin is a very old drug. It is a plasma expander which has been in use ever since the Second World War, when it was developed as a result of the need to have a stable plasma protein solution able to be used in battlefield conditions, particularly in conditions of great heat and where there was no ability to produce frozen or refrigerated storage, such as in the desert battles in the Second World War. And also, first use of albumin was described in the injuries suffered after the Japanese attack on Pearl Harbor. So this is an old product which for many years was taken for granted as being a useful plasma expander in acute situations. Over the past 20 years, we have had occasion to question this use and to have the ability to investigate albumin in the light of evidence-based medicine. Let us talk a bit about the basic physiology of fluid exchange. We know that the total body water constitutes 60% of body weight, and 2/3 of this is bound within the cellular environment. The extracellular fluid volume is composed in a majority of 2/3 interstitial fluid outside the circulation, and about 1/3, 5 liters, is composed of the blood volume, of which a certain amount is occupied by the red cell mass, and the rest is in the plasma. Now, nowadays, we have developed further our ideas about the retention of fluid within the vasculature. And rather than seeing the blood vessels as a passive channel for the passage of fluid, we are aware of a much more dynamic and active situation involving the relatively recently described glycocalyx membrane lining the lumen of the blood vessels. This is now acknowledged to be actually the largest organ in the body. It is a complex membrane consisting of glycoproteins and other entities, and very importantly punctured with these micro channels through which fluid passes in and out of the circulation. This is an active, energy requiring type of procedure, and it is extremely important, especially in the context of what we are talking about today. There are many numerous excellent reviews on the role of the glycocalyx in fluid exchange. I should perhaps say that these slides are available to anybody who wants them. I have given them to the conference on the computer, and if anybody wants to email me, they can get them through email. So we have a lot of ground to cover, so kindly just give me your attention and don't worry about taking any notes. Okay. Now, in relation to how this complex intravascular structure goes about the job of transferring fluid, you all know from your basic medicine, especially if you did this many years ago, that the original hypothesis of how fluid is exchanged or across the vasculature is basically dictated by the hydrostatic and osmotic pressures which are exerted by the blood pressure as well as by the proteins and any other colloids which exert a pressure either way across the blood vessels. This hypothesis was developed more than 100 years ago, before the discovery of the glycocalyx, and it involved, as an important component of the way in which fluid balance is maintained, the supposition that reabsorption occurs after exusion of the fluid at the end of the vasculature. We know today that this does not happen, and that in fact extruded fluid is returned to the blood vessels purely through the lymphatic flow. We also know that the glycocalyx layer itself is crucial in this, and that its health and the maintenance of its health is very important in ensuring that this happens. We know that there are disease states which damage the glycocalyx and which therefore damage the ability for fluid to be retained and returned into the circulation. And I quite like these two slides which I'm going to show you now, which are obtained from the publication referred to over here, which shows how the original Starling hypothesis, as I have said, is now altered in our minds in relation to the role of the glycocalyx. So in this particular slide, we are seeing this cartonic representation of the intravascular and the interstitial space and the passage of fluid across. And this is the situation where we have a healthy glycocalyx. As I said, there is no reabsorption at the end of the vasculature. Lymphatic flow is the only pathway, and the interstitial fluid space protein does not influence filtration. Albumin, in this instance, is in constant flux across the vascular barrier. It is important, as I shall note again later, to realize that 2/3 of the body albumin is actually outside the extravascular circulation. It is in the interstitial space. That is therefore the situation in a condition of good health. When we have in critical illness a pathological situation, we see that there is a shrinkage in the intravascular space, so that actually we start developing the condition of hypovolemia, and albumin flux is increased as a result of punctures in the glycocalyx, resulting in drainage of the albumin and the decreased concentration in the plasma as opposed to the interstitial space. The interstitial fluid space concentration does not still influence filtration, and since lymphatic clearance is overwhelmed, there is inadequate return to the vascular circulation, and we have the development of interstitial edema, a more complex and more dynamic situation than our original ideas imparted by Starling. And we have accrued over the years evidence that albumin, in relation to this dynamic situation of fluid exchange, has an important role. This is a series of experiments involving a guinea pig heart model in which the vasculature of the guinea pig heart was damaged deliberately, and the endothelial glycocalyx was subjected to a pathological insult. And therefore, this led to extravasation of fluid, of loss of fluid from the vasculature, and the development of tissue edema. And then the experiment was continued to result in perfusing the heart with different types of fluids. And we have here saline as a crystalloid, hydroxyethyl starch as an artificial colloid, and two different concentrations of human albumin. And the important thing from this series of experiments is that the transudate formation, that means what is coming out of the heart as a result of this experiment, is less with albumin, showing that albumin is actually retaining a capacity to keep the fluid within the vasculature of the heart, which is superior to that of the hydroxyethyl starch or of the crystalloid solution. The message from this is that albumin actually has a reparative capacity for the damaged glycocalyx. We shall discuss why this should be the case as we go along the talk. Now let's say a few words about the basic physiology of albumin. Albumin is, like most proteins, synthesized in the liver. It is then secreted into the extravascular circulation, and then moves into the extracellular space, where, as I have said, 2/3 of it is found in normal situations, and is then returned, as I have indicated, mostly through lymphatic flow. The structure of the albumin molecule has been extensively studied and is very well characterized. And you can see it over here in a crystalline form. Albumin accounts for about 50 to 60% of the plasma proteins, but has an extra, non-commensurate contribution to the colloidal osmotic pressure. About 75% of the colloidal osmotic pressure is contributed by albumin. 60%, as I said, of the total albumin mass is actually outside the circulation and the interstitial fluid. Besides being a contributor, and this is extremely important in our current ideas about albumin, besides being a contributor to oncotic transfer of water, what we might think of as a fairly passive kind of activity, albumin is a very dynamic molecule, as we know now, and through structural features can bind reversibly a large number of entities. It reversibly binds cations and anions, and it also transports drugs and has several important binding sites, which we shall encounter more of in this talk, including a cysteine residue at position 34, which binds, very importantly, reactive oxygen species. This, as we shall see, is of crucial importance in the redox balance of the whole physiology. It has a terminal which binds copper and nickel and other metals, and several other binding sites, as I said, which can bind different types of toxins, including endotoxin, as well as other metals, and a large variety of drugs. Albumin, therefore, is an extremely important molecule in terms of maintaining normal physiology. And therefore, it is important to realize that despite this, the very rare condition, analbuminemia, is superficially described in some aspects of the literature as being relatively benign. Analbuminemia is actually a very, very rare disease, and there is, in fact, a registry which is maintained to record whatever cases appear in clinical practice. And as of 2 or 3 years ago, there were only about 50 cases. In fact, when anybody discovers a case of an albuminemia, it is a good occasion to get yourself another publication. It's a relatively rare disease. It's a very rare disease and a relatively benign condition. You will find in some of the publications, especially the older ones, that the patients appear to have nothing wrong with them. They seem to have reasonably normal lives and so on. This is, however, a misconception. Actually, analbuminemia, in terms of the homozygous state, is probably a lethal condition in utero. In other words, if you have the defective gene on both chromosomes, the chances of a normal birth are very low. With the autosomal recessive condition, the situation is relatively benign. However, if you look at family history, you will find that there is a high sibling neonatal mortality, and that the lack of albumin in the 2nd or 3rd trimester may fail to protect against hyperalbuminemia and result in death. Survival to birth, as I said, for homozygotes is rare. Now, how do people who manage to survive maintain a relatively normal life? This is through compensation in relation to the plasma protein composition to allow an oncotic pressure to be maintained despite the fact that there is no albumin. And you can see here an electrocardiograph which is showing you the composition. As you can see, it's very abnormal compared to a normal chromatogram for a normal person in a person which has albuminemia. This is achieved over the course of life, and we actually know that if we infuse albumin in these individuals, there is a compensatory feedback mechanism which presses down particularly these extraordinary high levels of lipids which is found in these individuals. So, in other words, albumin is important. It is essential for survival. People who do not have albumin are very rare for the simple reason that most of them die before they are born. And we have a dynamic molecule with a large number of functions intimately linked to its complex structure. I have already spoken about the oncotic pressure and about the various transport functions. The very important antioxidant function, I will go into more detail, contributed mostly by cysteine 34 residues. We have, very importantly, endothelial stabilization. This is linked to the function which I have already discussed in terms of the protection of the glycocalyx. Albumin is a good inhibitor of the entities which activate and render unstable the endothelium, as well as being a good immunomodulator in these circumstances. Now, to go back to the body fluid distribution and what happens when we infuse different types of fluids, and I know that this is very familiar probably to all of you. This is the situation, as I have discussed before, in terms of the normal distribution of water between the various compartments, the plasma and the interstitial fluids comprising the extracellular compartment and the majority within the cells. This is what happens when we infuse 5% albumin. Since we have essentially a normal oncotic solution which is retained within the extravascular circulation, we simply have an expansion of the extravascular space and little effect on the other compartments. If, on the other hand, we infuse normal saline or most other crystalloids, the conventional picture is that we will lose a lot, about 2/3 of the infused fluid, to the extravascular space and distribute this mostly in the interstitium. On the other hand, if we infuse a hyperoncotic solution of a colloid, in this instance 25% albumin, the converse will occur, and we will get a drawing in of water from the extravascular spaces, an expansion of plasma volume, and the consequent depletion of water from the other compartments. I want to say something in particular about the antioxidant capacity of albumin, because I am leading towards the concept that albumin is not just a colloid to expand the plasma volume, but may well have other more interesting and therapeutically useful features. As I've said, albumin's cysteine-rich residue with a single exposed thiol group is contributing the principal extracellular antioxidant found in human plasma. This is done through standard, well-understood intracellular activities involving the transfer of sulfhydryl groups, and this balance becomes dysfunctional in states of acute illness, states like sepsis and similar types of illnesses. So if we look at this kind of study performed by Emory University, Professor Martin, you can see that in patients infused with a 25% solution of albumin compared with saline as a placebo, the actual antioxidant capacity and the total level of thiols measurable in the plasma increases remarkably as this is mobilized after the infusion of albumin, whereas with the placebo-treated group, the increases are, although present because of the infusion of fluid, are much less. So we think that this is actually a very important manifestation of a possibly therapeutically useful process. Now, so let's talk a bit about therapeutics. Albumin, as I have said, for many years was unquestioned as the colloid of choice. As the years have gone by, and this afternoon we will talk more about clinical trials, clinical studies started to perhaps throw doubts on this kind of common sense in relation to fluid therapy. And of course, in the 1980s, we started to get the development of evidence-based medicine. So this is an extract from the many Cochrane reviews on fluid therapy, and in this instance, we've got albumin or plasma protein fraction, and I will be making a point later on about the differences between therapeutic albumin preparations. But in this instance, we have one of the famous colloid versus crystalloid comparisons through a meta-analysis, in this instance comparing albumin or PPF versus crystalloid. I would hope I'm not going too fast for the colleague who is translating. If I am, she may impart this sentiment to the audience, and I'm sure there are people in the audience who will make me aware of it. Okay, so in terms of large meta-analytic type analysis, there is very little difference in terms of resuscitation capacity of albumin compared to crystalloids. Large meta-analytic type analysis. I emphasize the fact. Now we know nowadays that it is actually very difficult to extract good data from this type of traditional analysis. So I am going to discuss with you assessment of summaries of data using a different approach. And this is the approach of so-called network meta-analysis. And in network meta-analysis, we have a much more powerful technique because we are able to compare not just treatments which are compared in a clinical trial head-to-head, but we are able to compare treatments which are not necessarily comparable in the original clinical trial. So that using the network statistical approach, for example, if we have, let's just say, trials comparing hydroxyethyl starch to albumin and trials comparing hydroxyethyl starch to saline and trials comparing albumin to saline, we can then use these types of data using a statistical Bayesian-based approach to be able to increase the power of a comparison, for example, between albumin and hydroxyethyl starch through the bridge, if you like, the network, which includes another comparator such as saline. So that you can compare A, B, and C, and as well as comparing A and C, although you have not compared A and C directly. It is a very interesting technique which in my research work we have used extensively. This study, which was published in the British Journal of Anesthesia last year, used network meta-analysis in order to compare the outcomes of these various trials. And we shall go in detail over all these trials in the last talk today, if you are still surviving. So this is the SAFE study comparing albumin versus saline. This is the FEAST study comparing albumin with saline in terms of bolus or non-bolus in children with malaria. This is the CHEST study comparing hydroxyethyl starch. The SICK study, again, comparing hydroxyethyl starch to crystalloid, and so on and so forth. All these studies were therefore distilled, if you like, through the technique of network meta-analysis, and this is the result. And what we find, and is commented upon in this study, that we get this data, which is showing us the various comparisons and giving us the relative risks, the risk of confounding, risk of publication balance, and very importantly, the mortality rates. And basically, what we can start to assess through these types of analysis is the capacity to indicate statistically the relative benefit of different treatments. Basically, what the study concludes is that many of the types of trials which we have led us to essentially very similar results, or results which cannot be concluded as to whether one fluid or other is superior on the basis of these trials. And I think that the problem is very simple, and it is agreed now that these so-called large, pragmatic trials in acute care, intensive care populations are not very capable of discerning differences in efficacy between the different fluids when we have such a large number of contributing factors in the original illness. But we can make some conclusions if we draw upon prospectively identifying subgroups of different conditions within these trials. For example, in the SAFE study, which was done in my country and which I will describe in more detail this afternoon, this was a study, a very large pragmatic trial, still the largest of its kind, 7,000 patients in its arm, comparing albumin to normal saline. This study basically found that over the whole of the population, there was absolutely no difference in mortality between the two fluids. But when examining the predefined subgroup of patients with traumatic brain injury, this picture changes dramatically, and you can see, and I'm sure that you are familiar with the SAFE study, that mortality is significantly increased in the patients given albumin compared to the patients given saline, and this is shown both at the primary endpoint of 28 days, but continues over 2 years of follow-up, and it is manifested as well in abnormalities in the intracranial pressure. And you can read the original papers of Simon Pfimfer and John Myberg on this, and their hypothesis as to why this happens. The message from this is that it would certainly not be, I think, very advisable or ethical to use albumin in patients who have TBI. So let's go back to Cochrane. And basically, with Cochrane, in the latest review of colloids versus crystalloids, we get a reiteration of the fact that in this very large now review, we are comparing albumin, hydroxyethyl starch, gelatin, and dextran, relatively few studies with these rather archaic type expanders, but hydroxyethyl starch and albumin are still the biggest competitors for the colloid market. And the usual, I think that this is a very common statement from Cochrane reviews, is that there is no evidence from the RCTs that resuscitation with colloids reduces the mortality compared with crystalloids in patients with acute illness, trauma, burns, etc. However, importantly, and we will discuss this in more detail, the use of hydroxyethyl starch might increase mortality. This is nowadays, I think, fairly well established. But as colloids are not associated with an improvement in survival and considerably more expensive than crystalloids, it is hard to see how their continued use in clinical practice can be justified. I'm going to talk about the question of costs later on in this talk. I think it is very legitimate to make this kind of statement. We are all involved in delivering healthcare, and healthcare funding is increasingly scarce in any country, irrespective of its economic situation. But I think the other issue to be kept in mind is that in these large pragmatic trials, it is difficult to be able to generate the level of power required to give us statistical significance. And this is shown in various ways, as I shall discuss. But I think that the evidence is accruing that with albumin, whereas the Cochrane conclusion that albumin, like other colloids, is not significantly superior in terms of large populations pragmatically studied versus a crystalloid, I think we can, on the basis of the molecular structure that we know of albumin, develop some possible hypotheses as to how this drug can be more useful and test them in clinical trials, or, if necessary, identify prospectively groups of patients which we can assess after the trial. So we are talking here about the range of physiological properties which I have already discussed, leading to hypothesis building in sepsis, hepatology, some aspects of pulmonology, cardioarterial bypass grafting, burns, and some other conditions. I have chosen some of these conditions where I think the evidence lends itself to a continued examination of the use of albumin. These are all linked, as I have said, to the particular structural features which I outlined in earlier slides. So if we talk about sepsis, this has become a very interesting subject over the past 10 years, and as people involved in acute care, you know what a huge problem sepsis is, and we shall discuss this in more detail in the last talk. But going back to the features of albumin in relation to sepsis, if we examine what features of the microcirculation are disturbed in sepsis, we can see all these various inputs. We can see some aspects of these which might well be ameliorated through albumin, such as the disturbance of the rheology of the blood cells, the deformability of the blood cells, of the red blood cells, increased microvascular permeability, edema formation. All these things are found in sepsis, endothelial activation, and as I have shown, many of these types of situations are improved in vitro experiments, by the presence of albumin. So it is legitimate to try to assess this in the clinical environment. Also, interestingly, and this is linked to the preliminary observation which I showed you in relation to the perfusion of the guinea pig heart, interestingly, although in sepsis we do definitely see a huge increase in microvascular permeability due to the damage in the vessel wall, we also see that in most trials and in most studies, when we infuse albumin in sepsis, it is retained within the circulation, leading us to the hypothesis that albumin is providing a more dynamic role than simply an oncotic action which would be lost if it is immediately cleared out of the circulation through the damage in the vessel wall. This is just one study. There have been many others, and I will show more slides in later talks which show that when we infuse albumin in septic patients, we get an increase in the measurable albumin and we get an expansion in the plasma volume. And looking at the concept of subgroup analysis, whereby prospectively before the trial, prospectively identifying septic patients as being a target for analysis after the trial is complete, we can see that this was indeed the case, and that when the SAFE investigators looked at the mortality in the specific group which was in severe sepsis, they found an interestingly significant drop in this mortality. Now, this is, of course, not a population of purely septic patients. It was a large pragmatic trial. The patients with sepsis were, as much as possible, prospectively identified. This is not the ideal way to generate therapeutic proof, but it is an indicator and a good basis for further trials, which, as I shall show, have been done. This is a network meta-analysis which was done by my group a few years ago. And in this meta-analysis, we did exactly what I showed you in the other meta-analysis, which was later published, in which we compared albumin, crystalloid, and hydroxyethyl starch in relation to mortality in sepsis. And in this relatively modest study, using the trials which were available, I will describe this later on in the last talk in relation to septic shock, we found that it is indeed the case. This is the particular way of showing this type of result with these rankings. Don't worry about the statistics. Basically, it shows that albumin is overwhelmingly given the highest rank in relation to decreasing mortality in these septic patients relative to crystalloid and to hydroxyethyl starch. So tentatively, we can say that albumin appears to have a reasonable hope of evidence in sepsis, and later on, when I speak about sepsis and septic shock, I hope to demonstrate this to some greater extent. What about other indications? Well, although curiously not in Europe, and I suspect not even in Latin America, but in the United States, albumin enjoys a huge vogue. It's a very important market for the plasma companies in its use in cardiac surgery. And there is a large, reasonably large literature to demonstrate that there is some reason for this. First of all, hypoalbuminemia is associated with higher morbidity and mortality in cardiac surgery. There's nothing unusual about this. Hypoalbuminemia is a very good predictor of morbidity and mortality in most cases of illness, especially acute illness. And if it was as simple as that, people who advocate for albumin would be very happy, because if it was just that leading to the consumption of albumin, there would be nothing to discuss. However, it is the case, as is shown in the Cochrane types of reviews, that despite hypoalbuminemia being a good predictor of mortality, the converse is not the case. That if we correct the hypoalbuminemia with albumin infusion, it is by no means the case that we always get a reversal of this problem. And there are many ways to analyze this. It is, however, the case that in the case of cardiac surgery, perioperative administration of albumin has been shown to decrease mortality, and this has been associated with a better maintenance of hemodynamic stability, especially the patients who underwent acute normovolemic hemodilution. And very importantly, in matters involving CABG and cardiac surgery, there was no increase in the bleeding risk. I apologize, I have to drink every so often because my voice gives out, especially as I have a cold. Now, this is a hopelessly complicated slide. Don't worry too much about it. This is simply another meta-analysis. You are familiar with how complicated meta-analyses look. But this is basically colloids in cardiopulmonary bypass, and what we've got here, you can refer to the original publication, but what we've got here is a comparison between the various different types of colloids, and most of the data is albumin and hydroxyethyl starch. And the important thing in this kind of analysis is that it's unquestionably the case that in terms of bleeding type complications, hydroxyethyl starch contributes greatly to post-operative blood loss and reoperation because of bleeding, whereas albumin does not have this complication. We know nowadays, and the whole question of hydroxyethyl starch is very controversial. We'll say something about it. As I said in the last talk, it's difficult not to have these two talks overlap, but we know that the hydroxyethyl starches, the various generations of these synthetic compounds, have a profound effect on various aspects of hemostasis, particularly platelets and sequestration of von Willebrand factor from the circulation. So this is not very surprising. So cardiac surgery, we seem to have some evidence. What about hepatology? Hepatology is, in my view, the one area of clinical acute medicine where the evidence base of albumin is very solid, and we can see an increase of appreciation for this in future years. This is showing us the effect of albumin on systemic hemodynamics in cirrhosis. So if we infuse albumin, we obviously get an expansion in the intravascular volume, we get an increase in the cardiac preload, an improvement in left ventricular function, and overall an improvement in any circulatory dysfunction as a result of cirrhosis. And this is, if you like, the passive aspect of albumin, the oncotic aspect of albumin, but also we have the dynamic, biochemically mediated action of albumin, inhibition of endothelial activation, decreased nitrous oxide synthesis, and increased systemic vascular resistance, also leading to improvement of circulatory dysfunction. Does this actually happen? Well, if we look at the various clinical conditions, so if we look at patients with severe tense ascites, we can see that in this is an open label study examining survival in patients who received diuretics and albumin. You can see that over the months, the Kaplan-Meier shows us a very nice, significant, unequivocal improved survival in the patients which were supplemented in terms of their water removal regimens with albumin. So I think that this is now fairly established, and we have protocols to assess which of the patients need to actually be given albumin relative at the moment to the actual volume of acidic fluid which is drawn by paracentesis. And there is a lot more to be said about that in terms of the possible continued examination of individualizing the patient relative to somewhat more sophisticated clinical indicators than straightforward volume depletion. And here we can see the other aspect which I spoke about, the non-oncotic contribution of albumin, because here we've got a comparison of albumin and synthetic colloids in large volume paracentesis. So if the action is mediated purely through the oncotic volume replacement aspect, we would expect a reasonably equivalent clinical effect. But in fact, we see that albumin relative to, in this instance, dextran or polyglycerine has an enhanced capacity to improve post-paracentesis circulatory dysfunction. The patients given albumin on a gram per gram basis relative to the patients given the synthetic colloids did considerably better. And we hypothesize on this basis that the reason is being contributed by the particular enhanced properties of albumin involving inhibition of endothelial activation and all the other measures which I have described. And if we look again at meta-analysis, nowadays we can never avoid having to look at meta-analysis, we can see that in both prevention of paracentesis-induced circulatory dysfunction and also mortality after paracentesis, in this particular study performed by Professor Bernardi in Bologna, we can see a very significant effect favoring albumin unequivocally. So I think that this is definitely the case, that this is an area of activity where we can justify albumin. And we can also look at particular complications of liver disease and cirrhosis, and this is spontaneous bacterial peritonitis, a very dreaded complication in cirrhosis, as you know, very well studied for albumin. There is very little now justification for having any doubt for the use of albumin in this particular disease, although we can always attempt to localize better the types of patients who do better in terms of receiving albumin. But you can see that both in terms of renal impairment, mortality in the hospital, and mortality after release, the patients who are being given albumin as well as the antibiotics are doing much better. So again, I think this is an unequivocal indication. So having said that, let me very quickly share with you some recent results of research I am involved in as to answer the question, how much albumin do we need? Now, this is a question which is uncertain. It involves a lot of uncertainty involving epidemiology of disease, involving different dosages, involving a lot of things in which practice varies across and between countries. And therefore, I think when we have this kind of situation of uncertainty, the technique of decision analysis is very useful to employ. going to describe some aspects of this technique. It is complex statistics. I don't understand it myself. I have a very nice, bright, young statistician who does this work for me. She explains it to me time and time again. I never understand it, but I'm convinced that she knows what she's talking about. So basically what we do in this kind of uncertainty, in this kind of decision analysis, is we try to line up the epidemiological and the clinical aspects in terms of in this particular exercise, it's looking at the United States, in terms of the epidemiology of the relevant diseases. This is showing us the situation for hepatology. So we're looking at 10 societies, SPB, and type 1 hepatorenal syndrome. And then we look at the actual clinical parameters in terms of the dosages and so on. And we synthesize these in a statistical model. Can't explain it to you any better than that. This particular paper will be published soon, so you can look at it there. All right. We do this also involving sensitivity analysis to give us some idea of the relative contributions which the various variables have an effect on the model. This allows us to get a better estimate of the result. And to cut a long and complicated story short, we find that when we do this kind of analysis, in this particular instance for liver disease, we find we need 157 grams of albumin per 1,000 population. And when we do similar models for sepsis and for cardiac type usage, we find another 108 grams or so and another 61 grams. So all in all, we would maintain at the moment that on the basis of the indications for which we have definite evidence-based use on the basis of clinical data, we can justify in terms of demand planning something like 320 grams of albumin per 1,000 population. Now you might say, well, so what? Well, I can tell you that there are many countries which consume much less. I have no idea what Uruguay consumes, but there are many countries, including, for example, Italy, where I do much work at the moment, which consume much more. They consume something like 600. And it was also very interesting that there is a lot of variation across a country. For example, the Italian province of Sardinia consumes about 1,100 grams per 1,000 population. It is the highest consuming part of the world in terms of albumin. It is very difficult to understand why these things happen. But I would say that in order to have rational therapeutic practice, we definitely need to understand why, before the people who actually pay for all this decide that abuse is enough and cut off the supply. Okay, something about cost effectiveness. This is a study from some years ago, a hypothetical study in which the safe sepsis subgroup was looked at in terms of the cost effectiveness of albumin use in this group, and it was basically found that relative to normal pharmacoeconomic criteria for cost effectiveness, the use of albumin in this particular group would have been considered cost effective. This is a study from France. This is a study performed by my group some time ago in which we did a fairly similar analysis in severe sepsis, but we also compared not just the albumin but also to crystalloid and through hydroxyethyl starch, and we found that it is indeed the case that the cost per life year gained for albumin was very much within the acceptable level, if you like, in terms of the established economies. In other words, paying for albumin is cost effective in severe sepsis in these countries, and in fact, hydroxyethyl starch comes to being much more expensive relative to albumin, because although a bottle of HES is much cheaper than a bottle of albumin, the complications, in particular renal replacement therapy and the treatment of bleeding from the bleeding resulting from HES, render the whole benefit of a cheap drug to be null and void. And we have done a similar model now, which is not yet published. This is just a decision tree, don't let it scare you, in which we have done exactly the same thing, looking at the cost effectiveness of albumin in spontaneous bacterial peritonitis. And this was just in order to get practice with using the exercise, because we knew the result before we actually did it. And it is indeed the case that using albumin as a supplement to antibiotics results in an increase in quality-adjusted life years saved which is very acceptable in terms of what is accepted by payer agencies. So we can say that in these indications where we have good clinical evidence, that we also have good pharmacokinetic evidence. I want to finish this talk, ladies and gentlemen, by delivering a message which, to me, is very important as someone who has a certain level of experience in the manufacture of plasma products. And this is albumin. When we say albumin, what do we mean? Albumin preparations are not albumin as we have it circulating in our blood. Albumin is manufactured using a complex chemical process, which in fact is very different across the different companies which make it. This is showing us a review from some years ago, the different fractionation processes which are used to make albumin. Albumin, as I said, was developed in World War II by the immortal Professor Cohn, Professor Edwin Cohn in Harvard University, and he developed his famous Cohn fractionation. Nowadays, you always read a paper saying albumin was produced by Cohn fractionation. Well, the fact of the matter is that there are many, many varieties of Cohn fractionation. Also, in some countries, including mine, Australia, we actually discarded Cohn fractionation and we use chromatography to purify albumin, which gives you a much purer product. So the point I seek to make is that different albumin preparations can be expected to behave differently because when you examine them in the laboratory, they are different. And I feel myself very strongly that this is one reason for the huge differences which we see in clinical trial results, whereby one clinical trial gives us one effect and another clinical trial gives us a different effect in pretty similar populations of patients. That we cannot assume that these drugs, that these preparations of albumin are actually generic. And here is some evidence, some interesting data from in vitro type studies to support what I am saying. You can see here different generations in this left-hand part of this complex slide, different generations of albumin preparations in Australia, whereby we have over the years gone from standard plasma protein solution, which is not albumin, it's an impure form, only 87% albumin, to 5% normal serum albumin, to 4 to 5% albumex, which is produced by chromatography, and so on. I want to make the point, the SAFE study was done with this drug, with 4% chromatographically produced albumin. This is the most pure albumin you can get in the world. It's much purer than anything else which is marketed in America or Europe. So beware of necessarily extending your ideas about albumin safety or otherwise from one clinical trial. Everybody quotes the SAFE study, but that's because it suits them. Okay, so you can see different generations of albumin giving us different incidences of adverse drug reactions and different concentrations of the relevant impurities such as pKa and so on. And all of these types of preparations were all lumped into the famous Cochrane report, which I will talk to you about in the afternoon. Most inappropriate. This is a bit of a more sophisticated type of study in which different albumin preparations have been studied in relation to that important characteristic, which I emphasized over the course of the talk, of the repression of endothelial inactivation, in this instance through measuring the exposure of the ECAM1 receptor. And you can see that these different preparations are giving us different results in this type of measurement. I reiterate, the message is not all albumin preparations are the same. And if I can therefore summarize in relation to this particular talk, I thank you very much for your patience, that albumin is indeed an essential, multifaceted natural protein, and the historical focus on its oncotic plasma volume expanding effects is now, I think, quite fortunately being overtaken by an interest in pharmacological properties. And these allow us to build hypotheses in relation to certain defined diseases. Clinical data, particularly I think in sepsis and cirrhosis,